Welcome back from the break. Molecular tumor boards play a pivotal role in translating complex genomic and molecular testing results to help inform clinical decision-making. As the use of comprehensive genomic profiling and other advanced testing approaches continues to expand across Canada, molecular tumor boards are increasingly central to ensuring consistent interpretation and equitable access to precision oncology expertise, as we were just chatting about in our last session. In this panel discussion, we're examining molecular tumor boards in practice and exploring how we can advance standardization and system readiness. For this discussion, please welcome Dr. Michael Raphael, medical oncologist at the Odette Cancer Center, Sunnybrook Health Sciences, and co-chair of CRAN's Medical Advisory Board, who will be moderating this discussion. We welcome Jennifer Willis, who represents the caregiver perspective. Jennifer is a caregiver to her spouse diagnosed with stage 3C cholangiocarcinoma. Dr. Alan Spatz, chief of the McGill University Health Center's Department of Laboratory Medicine and medical director of the Octalab. Professor Arndt Vogel, clinician scientist and medical oncologist at Toronto General Hospital and Princess Margaret Cancer Center. Dr. Aaron De Bruin, professional education and implementation manager at Genome BC. And Dr. Shantanu Banerjee, co-chair of the Conference Expert Steering Committee and medical oncologist and director of precision oncology and advanced therapeutics at Cancer Care Manitoba. A warm welcome to all of our panelists, and I will hand it over to you, Dr. Raphael.
Well, good afternoon, everybody. It is a wonderful June 18th. It's beautiful out after that heavy rain shower, and we're excited to spend the next little while with this group of experts talking about molecular tumor boards. And so, having done many of these sessions with CRAN before, I know we have a super educated and a super diverse audience of patients, caregivers, clinicians, scientists. But just to bring everyone onto the same page, when we talk about molecular tumor boards, we're basically talking about multidisciplinary meetings where clinicians, scientists, our pathology colleagues, nursing, allied health review complex genomic testing and think through what that means for patient care. And so as genomic testing becomes more common, we're finding more tumor alterations, but the hard part is actually figuring out which ones are actually usefully clinically for our patients. Because not every mutation that we find is actionable and not every targeted therapy is available, and the level of evidence can vary a lot. So a molecular tumor board really brings together different perspectives: medical oncology, pathology, molecular genetics, pharmacy, bioinformatics, and our clinical trials program. And the goal of these tumor boards is to interpret the genomic results in the context of the whole patient, their cancer type, prior treatments, current clinical situation, and their goals of care. And sometimes the discussions we have point towards a specific approved targeted therapy. Sometimes it identifies a clinical trial option or an off-label treatment to consider, or suggests the need for example, germline genetic assessment. And sometimes the most useful conclusion is the finding is interesting, but not currently actionable. So the value of a molecular tumor board is that it really helps turn complex genomic data into practical evidence-informed recommendations. It also helps clinicians navigate uncertainty, drug access issues, and the rapidly changing precision oncology landscape. So ultimately, molecular tumor boards are one way we make precision medicine more thoughtful and more consistent and clinically relevant for our patients. And so we have a list of objectives that the steering committee went through today. And the hope is that we will go through some questions that we've thought about with the clinical experts on this call. But as usual, more importantly, we want to hear from the audience and the questions that you have, and really hope to make this an engaging session. So you can pose questions through the chat, and we will be more than happy to address those and to talk about them. So the main objectives, there are three objectives of this session. The first is that we are going to examine the role that molecular tumor boards play in interpreting comprehensive genomic profiling and other advanced genomic testing results to support informed clinical decision-making. Objective number 2 is to explore current molecular tumor board models in Canada, including variations in implementation and opportunities to strengthen integration into care. And the third objective is to identify strategies to strengthen clinician education and knowledge sharing in support of genomic-informed care. And it's not listed here, but the fourth key objective is to ensure that the audience here leaves today satisfied with the quality of the content and the humor of the content, hopefully. So we'll start off today's session by inviting Jennifer, who comes with our patient and caregiver perspective, to tell us a little bit about things from the lived experience that they've gone through.
Thank you so much. And it really means a lot to me to be able to be here today and participate, to share our story, which hopefully will resonate through with folks in the conference. I will admit I didn't set out to learn about genetic testing and molecular tumor boards. My husband wasn't feeling well in August 2024. Went to the doctor, and 2 weeks later, I was taking him to Emerge, where he was diagnosed with cholangiocarcinoma, bile duct cancer, and within a matter of 2 days, had Whipple surgery, so significant abdominal surgery to remove not only the tumor, but the potential spread in his gastrointestinal tract. We went through that surgery, recovered. Finally, we're able to meet with our oncology team at Princess Margaret Hospital, who are wonderful. And they immediately said, let's do genetic testing. We said, of course. We were lucky enough to be able to participate in a clinical trial at the time for genetic testing. We went through my husband's treatment with chemotherapy and immunotherapy, and we were doing very well until, unfortunately, like most people's story, in June of last year, the cancer came back and had metastasized through his lymph nodes. When we met with the oncologist, the wonderful, wonderful Dr. Robert Grant at PMH, he asked and suggested that we do genetic testing. I paused. I thought, we've done genetic testing. Unfortunately, no. So important to understand as a caregiver the difference between human genome testing and tumor genetic testing. And very quickly, I learned to understand the differences. We were once again able to participate in a clinical trial for tumor-based testing, where we were able to do not only liquid biopsy testing, so a blood test that would test the genetic makeup of the tumor, but also then whole genome tumor sequencing that was able to provide us with, we hoped, answers and a much clearer decision point around treatment plan going forward. That unfortunately takes time to get through and to get done. So we were waiting and waiting. When the results finally came through, we were very excited when we read the report to be able to see that they were able to identify a specific genomic trait in the tumor that was treatable. Unfortunately, once again, what we learned was that the genetic testing results pointed to a treatment plan based on a BRCA2 mutation in my husband's cancer, and the treatment wasn't available through OHIP for tumors related to cholangiocarcinoma. So BRCA2 is a mutation that's commonly found in colon cancer, in breast cancer, but there's just not enough weight or heft in the research available today for OHIP to fund the treatment plan. So it was once again more information that you can take in, but another roadblock to try to limit. So we looked at a number of different options on what that would mean for our treatment plan going forward. My husband has been, like most patients, very brave in what he's been going through. But it was disheartening to find out that neither the ministry nor our personal coverage from a healthcare perspective was able to pay for the treatment that we needed. So we've now gone through private funding to try to be able to find an alternative way. It's all a lot. When you start through this journey as a patient, but as a caregiver, you think about managing schedules, managing routines, making sure appointments are met, taking notes, asking questions. But when you don't know the questions to ask, and when you're relying on the right level of information to come through, you feel as though you're not doing your job as a caregiver, and it's very stressful. What we also found was that a lot of the information still comes through in very clinical terms. So trying to decipher that information and make sense of what's there is also quite confusing, and you need to be able to listen carefully when you're in a highly emotional state, and be able to react and act quickly, which unfortunately we're not always at liberty to do. So I think if we were able to look at consistency of information flow in ways that patients can understand and caregivers can understand, not in a way that you need a PhD in molecular biology, we'd be able to be in a much better place. I think also if we were able to look at how our healthcare system emphasizes the need to focus on the genetic makeup of the tumor rather than the tumor's location. Is it breast, or is it biliary cancer, or is it a BRCA2 mutation? And try to focus back on that. I think we'd be a lot further ahead. But I defer to the experts on the panel today and hope they can help us shed some light on the types of testing that are available and the types of questions we need to ask as well as caregivers to be able to navigate through this.
Thank you, Jennifer, for sharing your story and your experience. And I think, there's a lot of points just to take away from what you've spoken about. One of the key things, and I understand from Philomena and the CRAN team that we have over 100 people who are attending this session online, which is really amazing. So there's going to be a wide range of expertise. Just to emphasize a few of the points, you touched on the difference between a germline mutation, something that we are born with, it's in our DNA, it's in our genes. That's what we're referring to when we talk about germline genetic testing. And sometimes we simply refer to genetic testing on the tumor, but what we're really talking about is somatic tumor profiling.
Mm-hmm.
So something that's happened within the tumor, and they are complementary, but they are not identical and they're not the same. And they are often both important to consider doing, as you've highlighted. And I think you've brought up a number of other excellent points that I hope that we'll discuss with our experts, particularly about, finding these mutations. And if you can't act on that finding because there's a drug, but it's prohibitively expensive or it's not available, is that information just more stress, more difficulty for the family? And almost as if maybe you should not have better off not knowing about it, because you have these very, very difficult choices that you have to make. I can share just one analogy that in the early days of FGFR2 inhibition, I had a patient with cholangiocarcinoma. We found this mutation. There was no access to drug in Canada. And they sold their house in order to be able to pay privately for pemigatinib. And, that's not a decision that someone should be having to make as they're going through a cancer diagnosis. So I thank you for sharing and putting some, perspective into why it's so important that we really give thought to the genomic findings that we're having and the importance of molecular tumor boards and considering all of these issues. And so next, we'll just sort of go and get the experts' perspectives on some of the on the role of molecular tumor boards. And so, just today, I reached out to Dr. Vogel because I have a patient with an IDH mutated cholangiocarcinoma, and I'm desperate to get them access to therapy. And unfortunately, neither of us have clinical trials. So, these are things that we're encountering in day-to-day practice. So maybe I'll start with you, Dr. Vogel. You have experience both in Canada and internationally. Can you tell us about your experience with molecular tumor boards and how they have helped or how they've been challenging to implement?
Yeah, thank you very much. And I think there are different layers we need to discuss. So one layer has already addressed by Jennifer, I think quite clearly in terms of, we need to do molecular testing for some tumor types. It's more important than for others. In cholangiocarcinoma, we have a lot of druggable alterations, and we always recommend to do it as early as possible. And I think both of you have addressed this point that not only testing needs to be done, the testing needs to be well done. So we should not miss any druggable alterations. Then we need to understand the report. and then we need to have access to the therapies, right? So but this is something. I mean, it's a kind of it's more like an access and reimbursement problem, I would say, which definitely needs to be addressed here. And I think this is. I mean, as you mentioned, I worked for 20 years in Germany, and in Germany we have quite decent access to new drugs and very fast. So I never encountered this problem. So this is something we need to address, that we have access to drugs that are approved and that have demonstrated evidence in clinical trials. But the other point you also mentioned is the question about the molecular tumor board. And I think this is something where it's not about access and evidence, because when we have evidence, we don't really need a molecular tumor board, in my view, because we know if you have an FGFR2 fusion, we need an FGFR inhibitor, right? When we have a BRCA mutation, we know platin is meaningful, PARP inhibitor may be useful. I mean, not a lot of evidence in BDC, but still, so we can extrapolate from other tumor types. The problem is when we find alterations for which we do not have a lot of evidence and no approvals, and we don't even know whether they are drivers and whether they are druggable. And for that, and I was kind of the head of the Center for Personalized Medicine in Hanover for a couple of years. And here we tried to organize molecular tumor boards with different like disciplines, pathology, molecular pathology, but also oncology, or the organ-specific oncologists, so that we were really a group where we sit together and discuss different genetic alterations and discuss, is it a driver, should we target this alteration, and is it meaningful? And that was also very, very helpful. And I think it's very important that we also develop these structures here. And I think there are already some attempts in different centers. But understanding all these genetic alterations we can detect today is also quite important. Yeah. And then the next problem, of course, always getting access to the drugs.
Thanks, Dr. Vogt. I think you bring up a number of important points, and I think that would lead me next towards Dr. Spatz. In your role as a pathologist and director of a laboratory medicine program, it's becoming increasingly apparent. Pathology has always been crucial to the art and the treatment in oncology. But as we're relying more and more on these molecular findings to guide our therapies, we're also relying more and more on our pathology colleagues to understand the molecular findings, what they mean. I think to share one example of, but the importance of close collaboration. I had no idea just a few years ago that when our lab was doing molecular profiling, they were doing next generation sequencing that was quite comprehensive. But at least in our center in Ontario, they only had funding to report out certain variants and certain mutations. And so there was a whole wealth of information that was also there behind the scenes, sitting inside of a computer, that if we simply communicated and reached out to our pathologists, that they could give us information about. So I was wondering if you could speak to, the role of how you view pathology in, molecular tumor boards more broadly as a part of the important care team for patients moving forward.
Thank you. So thank you very much for the invitation. It's a real pleasure to interact with all of you. So to answer your question, I think I'll get back to what Jennifer has mentioned. I think that her intervention actually covered 4 very important points. So the first one is that the information pertinent to a patient is fragmented. It's fragmented, it's at different places, it's sometimes in different labs, even sometimes in different cities. The primary role of a molecular tumor board is to act as a kind of a data broker on behalf of the patient, to integrate all this meaningful information into one place that will prepare actually the decision-making process. So that's one. The second thing is, Jennifer alluded to this interaction between what we call the phenotype, which is the very specific environment of the patient, different from the genotype, which is anything related to genes. And Jennifer alluded to the importance to get back to genes irrespective of the phenotype, which is not completely true, because there is nothing that is completely agnostic the value of a gene defect or an alteration will depend very much on the specific context. That could be the tumor type, or within the tumor, that could be what we call the immune microenvironment, which is specifically how the patient responds to her or his tumor. And this interaction between phenotype and genotype is exactly what's the main role of the pathologist. The pathologist is really an integrator in the cockpit, where there are two main buttons, the phenotype and the genotype, and other information that go together. The third thing Jennifer alluded to, very important, is the digestibility of the information, is the fact that the patient distraught by bad news will need to process different kinds of information, sometimes poorly transferred, sometimes even very well transferred, but in a mental state that does not allow processing. And here I think that an organization such as this one should help use AI tools to organize a digestibility filter of the information that is provided to a patient. I think this is really key, and we can sit together to do that. And finally, you alluded to that, Michael. There is the operational component. So in Quebec, we are lucky because we have created a molecular diagnostic network aligning all the stakeholders in the province. I'm chairing the cancer committee, and this allows actually to have a very aligned approach and to make decisions that are aligned in the province. And just to mention that I'm coming from a country, like, as I understand Dr. Fogel, where molecular tumor boards are just mandatory. You are not allowed in France, in the context of the cancer centers, to see a patient without going to a molecular tumor board. This is just standard of care. So we are just here discussing aligning Canada with what I would consider as international standards.
That's fascinating. I had no idea about the practice in France. That's really interesting. You bring up so many important points, and I think it's a nice segue, to getting Dr. De Bruyn's perspective, because as genomic testing becomes increasingly complex, I'm interested to know what strategies we need to strengthen clinician education. We talked about, patient education, but also clinician education, because we get all these terms that maybe, your average oncologist is not familiar with. You start seeing these reports and they talk about variant allele frequency and copy number alterations and variant of uncertain significance and loss of heterozygosity. And it all becomes sort of like a word salad as to interpret, what is this? Is this meaningful for my patient? So I'm interested to hear your perspective on education, not only for patients, but also for clinicians as well.
Absolutely, and thanks very much. And one of the things we're finding is that for the non-genetic specialists, the education is often similar to patients because, yes, they may have a few more medical terms, but their background in genetics is lacking. And so we find that we can actually develop a lot of the materials at the same level. And that requires us to start with some key competencies. And so Canada, unfortunately, doesn't have any competencies around genetics, but around the world, there are kind of a couple of key pieces. So one is having the confidence to have the conversations with patients to begin with. Understanding who's going to benefit, and then knowing that they have to be referred to a molecular tumor board or to the particular labs that will get them the tumor-based or the germline testing, and having the conversations around consent, and do the patients understand what testing they're going to go about. And all of this needs to be part of our oncologists and our family physicians and all of those people, because without those skills, these people aren't getting to the tumor boards. They don't know that these tests exist. They don't know that this happens. And so I think one role for the molecular tumor boards is really in helping to build some of these core skills of how do people access the molecular tumor board? What testing are available? To go back to Dr. Gill's suggestion of the public dashboard for testing available, like what resources can we build to do some of these things? And so here in BC, we've got a platform called Pathways that allows us to have point of care tools available for clinicians and makes it a little easier for them to find some of those standards of care. But it's only as good as what you know and how you know to find it. So having more standardized, and this is where we can really leverage that pan-Canadian approach. We're not big enough for each province to do this on our own. And so those basic concepts are something we can develop at a pan-Canadian approach.
Thank you for that. And I think that, there's so mmany challenges that we have to consider when it comes to molecular tumor boards. And so I guess, I'd go to Dr. Banerjee, as a busy clinician, one of the things that we have the least of is time. And so, I myself only treat GI cancers, but even only treating GI cancers, I already attend 2 tumor boards. I attend a colorectal tumor board and an HPV tumor board. And so, I struggle with the idea, and we have a molecular tumor board at Sunnybrook as well that anyone can attend from any site. But one of the main challenges is about the time. And so I'm interested how you see this in your busy practice, being able to integrate another tumor board and how we can think about that.
Yes, thank you for the question. No, it is, time is a big factor, and we're quite used to in the oncology field to make tumor boards a central part of our weekly activities. As you mentioned, you attend a couple a week, so do I, so do all of us in the various fields. And thankfully, molecular discussions are part of that process as they become more and more relevant to the cancers we treat. But I don't know how many others find their tumor boards, but there's a lot we have to get to, particularly in terms of volumes of cases that have to be discussed. And unfortunately, as a result of that, in regular disease tumor boards, we perhaps don't have the time to give each case and molecular uniqueness the depth of discussion it deserves. And it's really that missing element that prompted us to establish our own molecular tumor board. And one of the key elements that is central to our molecular tumor board that was brought up by others earlier in the session is really the concept of education. And it's educating around several aspects. It's educating around what types of tests are out there, what information is gathered with those tests, how do providers potentially access those tests? And then the second aspect is when results are obtained, putting them in the context both of the disease, but also in the larger context of cancer biology and understanding and connecting those two elements and seeing how does that body of information contribute to important treatment decisions for that patient. And so really it's that education piece, as even Dr. DeBruyn brought up in her comments, is really central. And yes, it does wind up being an extra time, but it's really an extra piece of time that gets focused on education of the community of providers at large. And I think that is a really important element that the molecular tumor boards provide that perhaps aren't addressed in other tumor boards that many of us participate in.
Yeah, no, thank you. I mean, you make a number of important points, and it's increasingly challenging. We have to find ways to carve out the time for these important tumor boards, and I found, and I'm sure others on the call found, that traditional tumor boards have really been more surgical focused. Most of the questions are about, can this operation be done? Should it be done? And I do think that we do need to create a space where there's more thought about the, the molecular aspects of the tumor and treatments that we can offer. One thing that's come up in a number of people's answers that I would, sort of just invite anyone to give me their thoughts on is really about this equity piece. And that equity piece is we identify these molecular alterations and we may or may not be able to actually act on them because we may not be able to get access to those therapies. And actually, maybe I'll just ask Jennifer a little bit more about your experience, if you're comfortable sharing it, because it really hurts as an oncologist. Philomena and I had a case just this week of someone with a KRAS G12C mutation who we fought tooth and nail to get access to a targeted therapy for them. And we were lucky in this case to be successful, but it's not always successful. And so it feels awful as the oncologist to know that there's a drug that exists out there that could help our patients and we can't get access to it. And I'm just wondering how that information is from the patient and the caregiver perspective.
Yeah, and I can only say I have so much empathy for the oncologists who go through this day in and day out, right? I know how emotional I can get sometimes dealing with our family's issues and my husband's treatment plan. But I know you guys fight tooth and nail every day for each and every one of your patients, and we really count on that. I think when we went through and got the results of the genetic testing, the initial research was a PARP inhibitor, and that's cost prohibitive. It is $12,000 a month for the treatment. It's something that we've been trying to work through both with the Ministry of Health, with our private insurance, with the drug companies themselves to try to understand what alternatives might be available. We're at a point right now where I think the comment was made before about mortgaging a house. We're not there yet. But it's retirement savings that we're looking at now, and how we're actually able to leverage family money. And it adds additional pressure that you shouldn't have to go through when you've already been given a diagnosis. I think the other piece is based on current clinical trial availability. There are very few in Canada that, and I'm not sure if that's based on size of our population, or what, but I keep looking at different jurisdictions, and we've heard talk about clinical trial availability in France, in Germany. We're just not seeing the same level of molecular-based diagnosis and molecular-based treatment plan clinical trials in Canada, which I think is very disheartening from a patient perspective when you're given this additional information. You start to think of a genetic mutation as the villain in the story, but it's also potentially the hero, right? If you're able to identify the genetic mutation and you're able to identify a treatment plan, that's hopeful. And unfortunately, that hope isn't always available.
Yeah, I mean, very, very well said. It gets me thinking, and I'll put this out to the panel about the level of evidence that we need to make recommendations to our patients about targeted therapy. And so, we know that there is this desire that in the future we'll be talking about more tumor agnostic treatments. So treatments that are not dependent on cholangiocarcinoma or pancreas cancer or breast cancer, but based off of mutation A, B, C, D. But we also know that there are many examples in the literature where there is a molecular alteration and we have an agent that targets it and there is a differential response across sites. And so the classic example is like HER2. We know that trastuzumab has been a long-standing treatment in the management of HER2-positive breast cancer, but we know that by itself, trastuzumab is extremely ineffective in HER2-positive cholangiocarcinoma, for example. And so if someone has a mutation, there's a natural desire to say, well, drug A targets that mutation. It worked in this other cancer. I'd like to try and access it in my cancer. And so I'm wondering if anyone on the panel can comment on their perspectives on, what level of evidence do we need, both in terms of asking our healthcare system to pay for it, but also asking our patients to consider that it's the right therapy for them. Anyone? Maybe Dr. Vogel has a bit of a smile, so maybe I'll pick on him.
I mean, this is a very difficult question, and I think not only we, but also the regulatory agencies and also all the agencies which are responsible for reimbursement are struggling with that. And honestly, I mean, I think we need to distinguish wishful thinking and hoping and trying to do everything from evidence-based medicine. And I agree that it's sometimes tempting to extrapolate findings from one tumor type to the other tumor types. And this is exactly the area where we need a molecular tumor board to really make this decision and draw the line how far we can go. So I mean, you took the example for HER2 positive cancers, right? And I think it's specifically in this low expression HER2 where we do see clearly and significant differences in outcome. And in cholangio, we need really this very strong 3+ expression, and we have seen that HER2 2+ we shouldn't treat. But again, to do that, we need evidence, right? And we only get evidence with prospective studies, right? And otherwise, it's really this wishful thinking approach, which may work sometimes, but again, we have limited resources, and we can't do that, right? And therefore, I think we should try to generate evidence. We should try to treat our patients in registries and protocols to at least document outcome. And we need to urge pharmaceutical companies to also invest into rare tumors. I think at the moment, with all the hype of the KRAS inhibitor, I mean, some of you would have been at ASCO at the plenary sessions, I would assume, and some of you maybe also stood up and saw the standing ovations for the daraxonrasib in pancreatic cancer. And we have seen this tremendous success. But when I go to these companies and ask to do trials in BTC, it's very difficult. Yeah. And I think we and all the patients and advocacy groups, we need to advocate, and we need to reach out to the pharmaceutical companies to also invest in the rare cancers, yeah, so that we can generate the evidence we need to provide support and care for these patients as well.
Thank you. Dr. Spatz.
Yeah, I think it's important, Michael, to realize that your question actually goes even upstream to what is reported in the comprehensive genomic profiling. And there are obviously two philosophies here. The first is to report any alteration, potentially actionable, irrespective of the specific healthcare environment we operate. And the second one is to report only alterations that are actionable in the specific environment associated with a drug that is reimbursed. And this creates a very important tension that I think everybody should be aware that most of the time, because we are in a social country where healthcare is addressed collectively, it's only the alterations that we call tier 1, which are the alterations with not only a high level of evidence that they are actionable, but at the same time associated with reimbursed medication that are reported. So we are missing information, and we are missing information because we address at the same time the landscape of reimbursed medication.
Yeah, I think, you raise an important point, and I really do think that when all these talks I've been to thinking about, comprehensive genomic profiling, molecular profiling, it just really emphasizes the importance of close collaboration and communication with pathology and with molecular genetics. Like our pathologists, as I'm sure is the case, at many centers attend our rounds. Obviously, they attend the molecular tumor boards, but they also attend HPV-MCC and GI-MCC because we rely on them so greatly to help us understand the pathology results. And we learn from each other, you know, and I think it's so important that that two-way communication continues, because there's a whole wealth of information, as I said, that can be sometimes hidden there in the lab. And as we learn more and more about tumor types, we're relying more and more on our pathologists to help us uncover that information. You know, a recent example was, you know, a patient was referred with a cholangiocarcinoma, and we said, did they have any actionable mutations? And they said, you know, no, based off of the testing that they had done. And then we're able to do more complex genomic profiling when they had an FBXW7, like a very rare mutation that most people who aren't subspecialized in cholangiocarcinoma may not know about. But now we found something, and I've been able to refer them down actually to Princess Margaret, to who Jennifer was mentioning about, Dr. Grant, who has a clinical trial targeting that mutation. And so there's so many different things. I think, you know, even as a subspecialist just in GI cancers, I find it difficult to keep my head wrapped around everything. And so I think we have to be humble, and we have to maintain humility about what we do and what we don't know, and make sure we're asking all of our colleagues for help. Dr. Banerjee.
Thanks for that. The point I was going to add is to go back to the original question, that unfortunately, often what we run into as oncologists in this situation across the country is that there isn't a uniformed sort of response to either access to molecular testing or what to do with the results. And we've talked many times in this venue and others about postal code lotteries in Canada in terms of getting access to certain therapies based on where you live. And I speaking to my own jurisdiction, I would say that sometimes having a more rare diagnosis has an advantage over something more common. So I'll speak to my own world of sarcoma, for example. It's a disease that I treat, but I also treat lung cancer. In lung cancer, we're fortunate that we have lots of randomized trial, worldwide studies that lead to drug approvals, and we've been fortunate to have dozens of drugs approved in a relatively short time. Whereas sarcoma is almost the opposite, in the sense that, you know, we have lots of rare entities where we may never see a randomized trial, and often dealing with small studies. And so, at least in my jurisdiction, I'm able to work with our healthcare administration and make case-by-case arguments to access off-label use of drugs. And it really comes down to, you know, what's available, how readily is it available, how much does it cost, and what is the evidence. And we're not necessarily looking for that tier 1 evidence in every situation, but it has to make biological sense. And sometimes you're kind of advocating for that on your own, but I think that's where the value of the molecular tumor board really comes in, where you have an opportunity of putting a few minds together who bring various levels of expertise, who then add that additional layer of support. Ideally, what we would like to see happen in the coming years is that there be less jurisdiction to jurisdiction variation, and that there's a more harmonized access process across the country.
Yeah, I think, thank you. You bring up, you know, so many points, and you know, I think that there's a real concern that if advances are happening more rapidly in certain areas, you know, as you spoke about the postal code lottery, the disparities in cancer care can broaden and broaden and broaden and broaden for our patients, which is certainly not something that we want in Canada. You know, I was just reflecting as you were speaking, is I think that we all agree that if someone has a mutation and there's a clinical trial, it's best for that patient to access that treatment on a clinical trial, on a structured protocol. One, because it gets the patient access to care. Two, because it generates knowledge that helps future patients, and we can learn more and more. But I do think that if there is no clinical trial that's available, I can completely understand patients' desire, and I think there should be more willingness of the funders to help patients get access to those therapies. Unfortunately, that is not, it sounds like Manitoba is a bit more lenient than Ontario is at times. We've got a whole bunch of engagement for the audience, and I've just got some questions posted in the chat here. And this is a really interesting one. And it's about basically the role of patients and caregivers in these molecular tumor boards and in tumor boards in general. And the question says, as we look to expand molecular tumor boards across the country, how can patients be actively engaged? How do you feel about patient groups or patient group representatives participating, they say silently, in molecular tumor boards to gain a better understanding of the process and to ensure a better support system for patients and caregivers? So I'm not sure if anyone wants to field that one.
I think from a caregiver perspective, I respect the boundaries of the tumor board. I think over time, I've stopped trying to master the language of healthcare. I'm not a clinician. I'm not a scientist. And I think that you need to be able to distance yourself somewhat as a caregiver from some of those very clinical discussions. I think the key point for me was, again, not trying to understand what the tumor board was going to discuss, although you do need to advocate for yourself. It's just making sure that you're asking the right questions, right? So what will the result change right now? What are we hoping testing will tell us, or what did it tell us? And what are the options available? You are the one in charge of your treatment plan. You're taking advice and input. So really understanding the options that are available, but trusting the experts is still very important.
Thank you for that. I wonder if any of the clinicians, what is your perspective on the attendance of patients, representatives at tumor boards? How do you feel about that? What are your thoughts? Dr. Banerjee.
I think one of the biggest barriers right now, whether it should be or not, but the reality is that we are bound by health information security, and having many of our clinical discussions open more broadly to an audience where we may not always be able to control who participates has some personal health information security concerns, and that is an integral part of all the health systems that we operate in. I'm not justifying it, but I'm stating it as a reality. I would argue that perhaps the best way forward through that is, as oncologists, we need to be better at understanding and articulating our patients' questions on their behalf at these meetings. And maybe that's what Jennifer was getting at in her comment. And that goes back to the education piece, is that our oncologists need to understand what is that question they're asking.
Yeah, I think you make some excellent points. We've had many discussions at Sunnybrook about involving patients or not, and the MCCs, and time and time again, it's come down to the patient confidentiality, and that we are trying to get through so many cases in such a short period of time. It would be hard to safeguard the patients and the other patients' information as well. So very, very challenging. I have a thought about molecular tumor boards, but before I do that, it could potentially change the flow of the topic. I'll go to Dr. Spatz, who has his hand up.
No, just to add that although I don't see the feasibility because of the patient confidentiality aspect, but clearly having patient driving communication initiative on how to better communicate the results of, for instance, at least for the lab perspective, the pathologist, the pathology reports and the molecular genetics reports would be very important. And I think that, again, in the AI era, I believe that we really need to jump on what it represents in terms of enhancements for the communication to the patient.
Yeah, I'd second that. I think we use a lot of ChatGPT in our house to try to decipher reports, decipher, the different level of test information that we get. And there's got to be a better way.
Exactly, obviously, but I think that we need here to have a more kind of a guided way.
No, I like that.
Yeah, and I mean, we are in an information age now where, for example, at my hospital, the results of everything are released to the patient immediately on my chart. So
Mhm.
they get their CT scans and they get their CT scan results even before maybe I've had a chance to sit down and to look at them and reflect on them. They get the results of their blood work. They see their pathology. And they see, reports saying significant growth or significant change, and they may not have the understanding to qualify that. So I think we have to be thoughtful of the way that our reports are being dictated now, understanding that they're patient facing, so that we ensure that we're accurate and we're describing things with good medical language, but at the same time, respecting that it's not just a clinician who's going to be reading these reports anymore. We've got another question in the chat. Maybe Dr. De Bruin, I'll go to you. It says, what do you view the role of clinical geneticists and genomics experts who maybe aren't, directly patient-facing in tumor boards?
So for me, this is an interesting space. I think they have an opportunity to, in some ways, they should and can be participating. You're right, they don't often see the patient themselves, but having that context of the clinical space does impact their analysis. And that's where, Michael, as you were talking about with the close collaboration, it's having those feedback loops between the tumor boards and the analysis team to be able to see those parallels and commonalities of where those maybe uncommon variants are going to actually have relevance based on the experience of the oncologist and such, so that when they are doing calling at another time, they may elevate that above spaces. It's also important around calling the variants of uncertain significance and understanding when those need to be reported and most oftenly when they don't. And that's where that experience and collaboration back and forth is critical from a geneticist perspective to really know where that variance might be, especially from that equity perspective, knowing that much of our data sets do come from a European ancestry.
Mhm.
Yeah, important for sure. So lots of questions coming up. So how can molecular tumor boards work with clinical trials navigator so that patients can potentially access clinical trials across Canada that may not be available in their center? Well, if someone's thinking about if they want to answer, I'll tell you, my perspective as a medical oncologist is that I think that we need to have a modernization of the way that clinical trials are run. Especially when we enter into the biomarker-driven area where trials are based off of a specific mutation that may be rare within a rare subset of cancer. So if we look at a rare cancer like cholangiocarcinoma, and we look at a rare subset of that cancer, and we start looking at mutations that are 1 or 2%, I think we need to get a lot more collaborative about the way that these clinical trials are done. Because the traditional clinical trial structure requires a humongous investment to set up the clinical trial at your cancer center, and it's concentrated at very few specific sites, and it potentially loses access to patients who could really benefit from those clinical trials, which harms the patient because they don't have access, and it harms the trial because it takes a lot longer for the information to be generated. A wonderful example is that in the cholangiocarcinoma space is the C3 initiative that several of us are members of as well, the Canadian Cholangiocarcinoma Collaboration, where they do help with navigation based off of molecular findings. Dr. Vogel.
Yeah, I think this is a very important point, and to be honest, I mean, when we did this and when I did this in Germany in the last 10 years, I mean, we always tried to link our molecular tumor boards to an infrastructure where we could capture the clinical trials, at least within Germany, which was already very difficult. And the problem is, I mean, we are struggling to keep our clinical trial site from PMH up to date. And I mean, we have some colleagues which are really reaching out every other week. So can you please review all the trials you have, and are they all up to date? And even there, we find there are some trials which have been closed a couple of weeks ago, which are still listed, and others which are open for weeks are not yet listed. Yeah, so having these clinical trials up to date is really essential. And honestly, I think it's a business. So what we do now is we go to clinicaltrial.gov, right? Then we find about trials in Singapore and in Ohio and whatever, right? And it's not really helpful, not that much at least. And having like at least country-based up-to-date lists of clinical trials, I think it would be extremely helpful. And I hope one day we need to get there. I mean, what we have discussed before, annotation of genetic alterations is the first step. Having a list and survey of clinical trials is the next one, right? So to really provide best access to potential treatments.
Dr. DeBruyn?
So in BC, we've actually got an example of this with the personalized oncogenomics program, which integrated a clinical trials navigator as part of their tumor board process. And so they would participate and be able to identify clinical trials that were available to the patients. And so overall, that was seen as a relatively successful space. I think the clinical trials groups can also help. I know there's a lot of initiatives around the idea of the N=1 clinical trials and being able to set up the framework so that these off-label prescriptions and treatments, while not being a formal clinical trial protocol, does follow a standardized protocol so that that data can actually be collected and analyzed moving forward.
Yeah, I think we're all trying to find ways to better link our patients to clinical trials, and with the increasing complexity of the patients we're seeing and the increasing complexity of the genetic information that we're accumulating, I think having dedicated people like clinical trials navigators is extremely important, because it's so easy to miss something. It's so easy to know about the clinical trials that are in your immediate area, but maybe don't know about the clinical trials that a patient would be willing to travel for a few hours away. So I think it's extremely important that we remember that it's not just the doctor and the patient. There's such a huge potential team of people that can help. And sometimes it's these quote unquote administrative roles that can be critical to getting patients connected to the care that they need the most. So a question, I mean, this is a very, very challenging question that's in the chat, is for patients in centers without molecular tumor boards, can they request their file to be reviewed by a molecular tumor board at another center? So I don't know, Dr. Banerjee, it sounds like you've got a really well-established molecular tumor board. For other patients in the province, is there any way that their information could be reviewed and presented at your center or similar?
So I'll correct by saying our molecular tumor board is in its nascency. I wouldn't say it's well established, but we have very concrete terms of reference as guiding principles.
Okay.
With that being said, could we potentially have discussion from external tumor boards? I wouldn't see a reason why not. I think, as I said, with the focus being predominantly education, as long as a provider would be willing to give kind of the minimum information we look for, a case could definitely be discussed from an educational perspective. I think one of the key elements to a successful molecular tumor board is the breadth and depth of the education that people attending have. Because the success of the molecular tumor board really depends on who's there and how willing they are to contribute. And that can vary from tumor board to tumor board. And my biggest experience with that was actually not at my center, but through a molecular tumor board that we had through CCTG to inform one of their disease agnostic studies. And you could tell from the moment the meeting kicked off by who signed in how productive that molecular tumor board was going to be. And it's those types of variations that ultimately we need to eliminate, and AI tools are being used for that. But from perhaps not for molecular tumor boards, but we've already, for example, started a pan-Canadian adolescent and young adult tumor board, for example. So there's centers from across the country, including some from the US that have joined, that share cases with respect to adolescent and young adult cancers. And I don't see why that philosophy could not be applied to more pan-molecular tumor board approach as well.
Yeah. Dr. Spatz?
So on Monday, June 22, the Health Ministry of Quebec will announce a strategic plan for clinical genomics in the province. And without going into the details of the plan, because this is still embargoed, one of the recommendations will be to have a provincial molecular tumor board. So to use either to create one for the province or to use the one that exists at the Jewish General Hospital. And this molecular tumor board will allow actually all patients in the province to get access to the molecular tumor board as needed, based on obviously complexity and treatment options.
Oh, that's amazing. That's amazing. It's amazing when you hear about these things that are happening in other provinces, and you're wishing that you could have those in your own province. So, that's great for taking the lead on that, and hopefully Ontario can soon follow. Yay. Okay. I'm going to stop being jealous, and I'm going to go on to the next question. We've only got a few more questions. It looks like we'll probably wrap up the session just a bit early, but just want to make sure we've addressed all the questions in the chat. Okay. These are pretty similar. So should molecular tumor boards be centralized to ensure high levels of expertise? I think we've sort of touched on that a little bit. And I'll tell you, I think just a thought that I wanted to bring up before is, I think molecular tumor boards are important both for informing the clinician about the potential treatment options for their patient, but at the same time for reining us in a bit. And what I mean by that is, I think you've heard a couple times in this call that we're as clinicians are deeply invested in the care of our patients, right? We want our patients to do well. We want them to get back access to treatments, and we want them to live longer and live better. And I think sometimes you get so attached and connected to these patients that you do sometimes lose some of the objectiveness of your thinking, and you start thinking about, well, maybe we should do this treatment. And it's because you're just a little bit too close to it. And I think that that's one of the values of molecular tumor boards, is helping rein back at times to say, okay, here's what is actually there, here's what the evidence is, and here's how we can support it. So that was just one comment I wanted to make, is that sometimes it's good to be able to speak with colleagues, because just if any of the patients on the line have any doubts at times, your oncologist really does care about you and stays up at night thinking about you. And so you also want them to be reined in at times. They may be really aggressive in a treatment they're recommending, but that's because they really care. I don't know if that made sense, but that's just sometimes the way I feel. So we're coming close to time. So I'll just invite anyone on the panel to give us some thoughts, some perspectives that they may have, anything that they really wanted to say that they perhaps haven't had a chance to. I'll go first with Dr. De Bruin.
Thanks very much. So a couple of things that we can think about is that oftentimes the education and support that we provide isn't documented in the papers and the clinical examples. And as we've highlighted, that can often be the success or failure as to how that discussion went. And so being able to really document what was provided before the tumor board and how that may have impacted things is actually a gap in the literature right now. When you search molecular tumor board in education, it's a pretty big desert. So I would encourage all of our clinicians to think about that as we go. The other thing I just wanted to bring up is that often these resources are siloed. They're in people's computer files. They're not necessarily available to the public. And so one of the things we're looking to do at Genome BC is leverage some of our resources that we've been doing to help folks access genomic data, is that we're looking to build a genomic education asset map that would help us to collect kind of the metadata of what types of things have been created and what they can be used for, which would allow us to then share these resources more broadly across the country. Because, as I said, these silos, when we talk about time, all of these things take time and energy to create. And if we have the opportunity to share that, I think we can do everybody a service. So,
Thank you so much. That's very helpful information. Dr. Spatz.
Yeah, so I think a very important component that has not been mentioned with the molecular tumor board is self-education. Is really that this is an extremely powerful tool to leverage the amount of knowledge among ourselves, colleagues, working in different specialty, working in different from different fields, different professions. And that's critical. For instance, we also now have different types of prescriptors, of prescribers of complex molecular genetic testing, including, and I think this is very right, but including, for instance, the nurse specialist. And obviously, we really need to put in place, and this is a very important gap we are having currently, is to find the right training and education for the professionals, irrespective of their origin, nurse or doctor, for instance, to get the right amount of education to understand the limitation of a test, to understand its risks, its nature, and what to do with the results. This goes just beyond just a webinar. This really takes specific set of training that does not exist at present and that we need to put in place.
Yeah, no, I thank you for that. That's a super important point, is really emphasizing like the role that this plays in education and ensuring that we truly understand the results that we are finding. As you were speaking, I was just reflecting on, I don't think this exists in the GI site, but I'm pretty sure that in like GU cancers, urologists prescribe a lot of these anti-cancer therapies. And always when I was training, I was like, I don't know about that. But, as maybe in the era where, of comprehensive genomic profiling, as more and more surgeons, you mentioned nurses, nurse practitioners, other allied health are going to be involved. It's just important that everyone's coming with a level playing field of knowledge, of understanding. And I think that, again, speaks to, relying on these molecular tumor boards to surround yourself with experts who truly understand the methodology of the testing and the interpretation, so that in the end, we're making the best recommendations possible for our patients. And I think, so we're getting towards the end of the time. And so I just wanted to, turn back to Jennifer again, because we are always trying to ground these sessions in the most important fact that at the heart of all this is the patients and the patient caregivers. And so I'm interested to hear, your sort of final thoughts about molecular tumor boards, their importance, and how you see these things moving forward from the patient and caregiver perspective.
Thank you. I think there's nothing that takes control away from a person more than being given a cancer diagnosis. And I think that when you look at the opportunities that are now available, the way the science is evolving, understanding how molecular tumor boards work starts to give you back some of that control, where you've got more information to make decisions. And that's a really important point. So again, I cannot urge enough to try to understand, ask the questions, what testing is available, what testing can I participate in, and just continue to push for more information. Understanding whether or not your hospital has access to a tumor board, as we've heard here, is a fundamental question as well. But getting access to the testing, asking for it, and advocating on your behalf is one of the best things you can do. I cannot say enough about the people that I've met through my husband's cancer journey, about the level of care and compassion that's given to patients. But it's a lot of information that comes fast and furious. So make sure you take the time to slow down and ask the important questions.
Thank you. That's such good parting advice. And I think, I want to say thank you to all the panelists. Obviously, thank you to CCRAN for putting on this wonderful conference and this wonderful session. And I think, the very reason why organizations like CCRAN exist is to help empower patients, right? Their motto of support, education, advocacy. So I think, tell the patients that you see sitting in the waiting room next to you, in the treatments chairs next to you, about CCRAN and about the sources of education and support that they can provide. Because, I think it takes an army to care for someone with cancer, and that includes not only doctors, nurses, pharmacists, but patient advocacy plays ever increasing role, especially in the era of biomarker-driven personalized oncology. And so I want to say thank you again to all the panelists. Thank you to CCRAN, and I will hand it back to Cassandra.
Thank you so much, Dr. Raphael. That was a really important discussion, and the molecular tumor boards have really been positioned not only as a strategy to improve patient care and improve patient outcomes, but also to enhance interprofessional education. And I think that's a really critical component as well. And it's very exciting to hear that some exciting news will be coming out of Odette next week. We very much look forward to hearing that announcement. So big thank you goes out to all of our expert panelists, Dr. Raphael for moderating, and of course, Jennifer for being with us and sharing your lived experience.